Good day, everybody. My name is Alik Farber. I'm the professor and chair of the Department of Surgery at Boston University Chubanian and Avedisian School of Medicine and surgeon-in-chief of Boston Medical Center. In the field of peripheral artery disease, and specifically in chronic limb-threatening ischemia, there's not a lot of evidence base that guides the decision-making for physicians in taking care of the patients. And to that end, in the past several years, there has been effort made both in Europe and the United States and North America to gain more of that evidence. The BEST-CLI trial, together with Basel-II trial, is such an effort to try to answer some of the important questions that are out there in how to best treat patients with chronic limb-threatening ischemia. The BEST-CLI data was the main study in the randomized comparison between open surgery and endovascular therapy in patients who had chronic limb-threatening ischemia and were candidates for both. This was published in the New England Journal of Medicine in December of 2022. While that was the main finding of the BEST-CLI trial, there is a lot of data that remains out there in the data set that could be analyzed. And the Novo Nordisk Foundation of Denmark has given the BEST-CLI investigators 25 million Danish kroner to try to answer more of the questions that remain within the data set. And to that end, we have done a number of subset analyses to try to get as much information out of this data set as we possibly could. And this may be one of the most extensive efforts where a group has gone far and deep to try to do that. And so we have more than 30 working groups across the world that have been busy over the course of the past year to try to answer some of the questions that still remain using subset analyses. Well, what I'm going to do in London next week is really share with you almost 15 of the 21 analyses that have recently been performed. So I don't think we have time to go through each one of these, but I can just give you a taste of what I'm going to talk about. I'm going to talk about causes and impact of endovascular technical failure, something that people really want to know about. The effect of optimal medical therapy and outcomes. The role of the Wi-Fi classification in the trial. We are also going to share results from the as-treated analysis. We're going to talk about our findings as it relates to the comparison of conduit for bypass in the BEST-CLI group, and the role of female gender, chronic kidney disease, diabetes, smoking, age, and other topics. So I plan on really giving a whirlwind tour of what we found at the Charing Cross during the time that I have. One of the analyses involves us looking at the effect of chronic kidney disease in patients with CLTI. And so we took the BEST-CLI cohort, and we split that up into 3 groups depending on glomerular filtration rate. We found that, in fact, glomerular filtration rate, or GFR, does directly correlate with mortality and major adverse limb events, and specifically in patients who are on dialysis. Endovascular therapy was associated with lower mortality, but increased rate of reinterventions. Absolutely. Even though by the time we're done with analyzing the BEST-CLI data set, we'll probably have approximately 40 subgroup analyses performed. There's still much more that needs to be answered. What is the best endovascular therapy to use in patients with CLTI, given the wide array of therapies that are out there? What about perfusion of the foot? What is the best way to measure that? How do we better understand this concept of a runoff into the foot? And which subgroups of patients really do best with surgical therapy, endovascular therapy, hybrid procedures, or no revascularization whatsoever? Is there a role to optimizing medical therapy to reduce the very high rate of mortality that these patients experience? And these are just some of the topics that still need answers.